Okay, let's let it be. Maybe it will not be a classic panel discussion, but I hope that we will launch a dialogue. And this is a finalizing panel. So, dealing with the consequences of the mild TBI, we'll got several presentations in the video record. So, the lady recorded it in really extreme conditions. And let me recommend the panelists that we have with us. First of all, the Director of Center of Mental Health and Rehabilitation Veterans, Lizova Polyana, Ksenia Вознесенко, neurobiologist Sergei Danilov, and Recovery Center, Mikhailo Kochetkov, physical therapist. And we have also, we will be having Oksana Lalka with the speech and language therapy, and also the Christina Rakis, the optometrist from James A. Haley Veterans Hospital. Ksenia, the floor is yours. So we smoothly move from military medicine to the area or scope of work that many of the professionals will deal after. I mean, dealing with treating the consequences of ECBT and MTBI. So this will be kind of same time complex and simple process since the acute period of trauma. So the toolbox, it's not so big, and mainly we base our activities on the common sense, on a healthy way of life, and it's easy. So it's not about treatment when you tell your patient about, and also we as a specialists we have to provide the educative work with your patient, and in order to educate your patient, you have to be educated yourself. So that is why our center exists in order to provide the skills and disseminate among these skills among the GPs and the rehab specialists. And so my so please put my presentation on screen. Why I mentioned that is easy and hard at the same time. So the complexity is that in order to overcome this trauma, we need really big human resource, and this is kind of challenge for us. So we have to know how it works, what does it do. So, and as Cassie mentioned, as you see the green circle, so we again say that we've got lots of trauma, or such trauma, and so several episodes will get in a row with the, let's say, relevant consequences. And this is not only about the number of cases, but also about the aid being provided in acute period. This is the data of the MOH of Ukraine. These are open data in quantity for the head in other parts. of the body, whether it's complex or not. And with CBI, you also see it on the screen. We talk here saying mild CBI, mild CBI, mild CBI, but again, this is a synonym for concussion. And that's why we're talking about concussion, brain concussion, as a result of a blow or blow wave. It's like a thriller. And the big complaint, the main complaint from the patients, it can be like road accidents and other cases, I mean, like household cases. Um, but what this trauma makes to the brain is a specific process, and that's why when you understand it, so you will know why we don't need lysine, the understanding of the process. When we understand well this process, so everything is getting its own place. It's a cascade of changes, having different manifestations and complaints. What is happening with the brain from explosion? I would like to say it's like a monster affecting the brain and the whole body. And since the whole body suffers because of the blast, and try to imagine the velocity of the wave. And here, the very important is the timeline. And I mean the atmospheric pressure. It's equals like in 10 meters diving. But when we're diving, we do it slowly. But this blow, it happens in milliseconds. Then hydrodynamic impact is formed. It's kind of liquid dynamic, I mean seismic dynamic. It's so that is through which the wave is propagating. And this front line of this wave with a high pressure and then sudden drop can form the micro bubbles, traumatizing the brain's vessel circulation. Everything happens on the micro level, micro inflammations of axons, and that's why we know why we don't do MRI. So it is prohibited to again to assign the MRI examination. So for any single procedure like MRI, you have to need the specific indications, same as for the pain in the back. So when people say, well, I have to make an MRI and I have a pain in my back, so but why? So these are the degenerative process like osteochondrosis, and it's like similar. I mean, similar to when you have the pain in the back. So the American recommendations say like only 5% are which serve as indication for MRI examination. So again, where is the complexity of studying such a trauma? It's really hard to model such trauma within the laboratory. It's hard to measure in real time when it happens to the living brain. Also, premorbidity condition, morbidity condition, age, psychological and emotional state of the patient that can worsen or worsening better into situation. I mean, the trauma is similar and the mechanism is the same, but the manifestations at every patient can differ. And it's really individual and customized. I mean, why it's hard to visualize and to confirm what lobes are most injured. And again, about this clinical chameleon, where's the, let's say, this so, why it is so hard to identify the claims, since they're not specific? They may develop, in any single situation, somatic, emotional, and cognitive. And so they are so kind of masking in, but this triada should be kept up. So the GPs should take it into consideration. So collect well the anamnesis and also to consider the combination of the claims, which can be the same and also the overlapping symptoms. Same, it's like same combinations of TBI and PTSD. They are masking each other, and it's really hard to measure, to identify. And treatment should be the same. And that's why we started to use in Lisova Polyana Center. Since we started to work at the mental health center, treating all the depressions, PTSDs, and so on, adaptation cases, but this comorbidity, it's really a specific of this war that requires different approaches. I mean, first of all, multidisciplinary, interdisciplinary team, and that's why, considering that we cannot structurize the injured objects, so what we have to do, first of all, focusing on the qualitative rehabilitation, qualitative recovery of the persons that is described in different guidelines, which really acknowledge the neuroplasticity of the brain. Hallelujah, we are very thankful to it. The brain is quite a complex system, but it can grow new connections to replace the areas. And there are lots of studies in neuroplasticity. Will not work with like 8 cups of coffee, 8 packs of cigarettes, and lying in bed. So I'm a concussed one. So neuroplasticity again should be launched, and here the person should be included by itself. It should be a partner approach of the doctor and patient, the compliance when you have to get a separate tune itself. And the thing that we provide, the treatment that we provide in Лісова Поляна, so, and you know that MOH
під своєму підпорядкуванні ми
of US in Ministry of Veterans Affairs, they possess really multidisciplinary and multi-layered healthcare facilities, and they created the coordination center for study and treatment. So in 2023, namely, they did a big review that interdisciplinary approach is working quite well in post-concussion syndrome. And this integrative approach, it's rather hard to implement since you have to create a big team to add lots of methods for the person in the course of recovery to be provided for 8 to 10 hours of involvement, and also the additional methods. So psychologists and neurologists should be within this team, and the sociological team. So with all clinical guidelines, we see that all the PTSD and sleeping disturbances, first of all, it's not a therapist, but psychotherapist in aiding such patients in others. Lots of physical therapy. Really few psychiatric hospitals have the physical therapists, and again the focus on neuroplasticity of the brain. Without involving the body, we will not get good results. And lots of social therapy, sure, very nicely working are complementary methods. I mean, this is not the primary line. There's acupuncture, yoga, like singing and dancing. And yoga is one of the most popular activity in our center. When we started doing it, so there's an enhanced sleep yoga for veterans. It's really a nice thing. So at the very beginning, I was doubting that our veterans will attend yoga therapy, but now we've got lots of patients in enhanced sleep yoga, respiratory yoga, and other types of yoga. Again, we involve education why we don't use IV lines and so on. And it's much easier to work with this since, as Katie showed, this expanded network. So for having several centers in Ukraine involved in the consequences of the TBI. Please have a look at this example. This is the epicenter clinic, for example. As Kathy mentioned, so we met with Sombayok. So this is the list of the 4 weeks rehab for the persons with MTBI. Try to get to grasp everything, as you see, the dietology, mindfulness, and open yoga, and so on. Just to read it all, it takes time. That's really cool, I would say. And sure, all these things, why they're so much precious. The people can take with them the skills that they've been developing in our center. Sure that we cannot improve everything, but we create new habits, new skills for the persons, and now they go on improving themselves. As to the challenges and actions, I will not dwell on them. They were exposed in the document, and we will tell about them tomorrow. You can scan it with the QR code. Those who are eager to involve their own expertise, so I invite you to add your ideas, and we will form a good document tomorrow that we will promote everywhere we can. And I can say that yes, we can recover everything, and even with that myth, so we're laughing at that we got the Afghanistan War Veterans Hospital before. They were also concussed. And the patients say, I'm already concussed, my dad was concussed, and I'll be also. Nothing will help. But this is really a myth. You can overcome everything, but you have really to put lots of efforts. That's why our following presentations will deal with the elements that you have to work on. This is the physical therapy in order to overcome the consequences our speaker will tell you about. And my beloved neighbor, Danilo, will also tell about how to develop cognitive skills. And Oksana Lalka, with her expertise as a speech and language therapist, and Christina as a optometrist. They say it's not about ophthalmology, it's a clinical specialty that is forming and telling you about the eye moving muscles and their links with the cortex. So we switch to Sergey. Sergey, the floor is yours.
Thank you so much. And I think I will show my presentation, because basically a little share of what Ksenia was telling about, a small percentage. I just want to tell what we were doing, and basically everything I want already is mentioned. Okay, everything I want to say is already mentioned about physical activity. Yeah, so yeah, everything I want to say. But we think that one of the key elements and elements we've been discussing like grave cases, how doctors make decisions. So we give a chance, give an opportunity to a person to understand what's happening to her or to him. Thanks to Ksenia, because mostly because she gave us access to patients. She was collecting data. Without it, we couldn't do it. So starting from 2022, we had our ANIMA, launched our ANIMA, the test, just to add the biomarker to usual questionnaire for a person to compare subjective feelings with objective stuff. I will not tell about this today. You can actually have like a separate discussion with me later. But I just want to say, speak of the test that we launched to, yeah, this is the test, how it's used. You can see Victor. Thank you. So, what are we doing basically? Yes. So, person is sitting next to laptop. Laptop is we turn it into an eye tracker, checking the movements, eye movements. We give some stimuli, and some machine learning model is analyzing this, and recommendations are given. So this is how it works. So it's quite a complicated technology, but we try to make it really simple for the person. Okay. How is concussion and brain trauma related to eye movement? Okay, so there are a lot of publications. I just put something that I took the first, but what is the consequence and the key element to shape these post-concussion? It's the problems with attention, yeah? When person cannot focus on a function. And the problem with performing functions, then it goes like in an avalanche mode, it impacts everything else. If person can restore a function, one definitely can restore something that Ksenia was speaking of. When person gets an opportunity and enough of will, let's say, to start going in for sports, the result will be much better than anything else. Yeah? So, how do you identify if a person definitely has this resource or not? Because this is a classical problem. Strokes and brain traumas, where is the tolerance window? What load can person take? Do we need to give any load to person or not? You remember that previously they always said, since childhood, okay, you have a concussion, they say, like a week, a month, you have to just stay in bed. Now, according to requirements, US requirements, if a kid had a sport trauma or concussion, the second day after it, going to school. If there is like fatigue, the teacher just sends him to have some rest on a mat. Doesn't matter how many minutes, like were there of minute or 5 or 20. So you need to instantly go to rehab, switch into rehab. We need to measure how much of a resource the person has. So there are so many tests where we use the analysis of how person, thanks to the eye movements, let's say with the eye movements, how attention is related to symptoms of brain traumas. One of the tests for U.S. sportsmen, they designed it there, King David test. One person quickly has to spell numbers, find these numbers, and put them in order, spell it. So you can see that it combined with eye tracking. And eye tracking is one of not so many biomarkers which are allowed by FDA to be used as biomarker for concussions. So there's one small problem. Last year we started doing this. Via some funds, I wanted to get grants to buy monitors, tracking monitors. These are expensive, and those that automatically register the movements of eyes when person is tracking something moving in the circle, and person is just, for 2 seconds, the data is accumulated. $11,000 per monitor, okay? And we didn't get the grant because they didn't understand why do you need that. Funds did not understand. So what do we want to do? We want to do it with just laptop webcams. Not just with average webcams, some complex tests, but to make it good for people. Because these stories from psychologists, you heard it many times, like that soldiers are filling out questionnaires, 200 questions, what they put there, what these surveys show. We need to have something very simple, very fast, very clear, like simple activity. When we want to identify the anxiety level, we show images. If person is responding to an image, there is emotion. I'll show you the study and tell you the idea. So the idea is if we evaluate how a person reads, when we read, we have very stereotypical movement of eyes. We have to stick to the same rhythm. It's the same dynamics. We have they're sequential movements of eyes. So we had like a small study. 50 people were there in the study. People with concussions compared to non-concussed people. Thanks to Ksenia, a little bit of data we gathered in Feofania, and we analyzed. You can see that horrible image, yeah? We analyze when they read the trajectory of eye movement, and basically, well, partially it looks like stabilization platform. It can show if the person has had concussion or not. This is a good method to identify if a person can control one's muscles. The same idea is here. So in King David test, if you just give person something to read and see how fast one is identifying the position of numbers, it doesn't give a good forecast. It doesn't tell us if there's concussion. But if we combine the data with the stability of eye movement, then it's specific enough, the indicator, yeah? So more than 80% of specificity. So we just told people to read, okay? And we checked the trajectory and used a couple of interesting methods. Our friends from Polytechnic Institute helped us, partners from Japan who designed one of the methods, and now we can see that in those previous studies we can differentiate people with concussions with person who has this post-concussion condition, you know? Like in 5 days it may be like okay, but it's still there. Manifestations of this condition, I mean. And how the eyes move, how the person blinks, the head tilts. Because when person has no resource, person starts blinking faster. To separate this information, one has to perceive and to split it into smaller blocks, okay? To process faster. Sometimes they do it like that and turn away from the test because there's not enough resource, the operational memory actually, to handle it. So they tilt their heads quite often. Some sporadic movements there are, so they just stop at the same line quite often to analyze it. So now we have this text. Imagine you have a very simple text like this long, okay, something from fiction, maybe even interesting. You read it and you click the images which are relevant or not, compatible with the test or not, or the text or not, and move to next one, next text, which is a little bit more difficult. And person has a couple of stages from simple to difficult text to assess where one feels that one is losing attention, okay? Later we will add some images, but it seems that it shows the condition properly of a person, and I hope by the end of the year we'll complete this thing, we'll finish the testing, and online person will have this test just to check where am I, like what is my level of impact. Maybe use this in recruiting just to see if the person had something previously, God forbid, before the concussion, just to compare something that we have now and we have then. This is not something just to put a tick in the box, give a diagnosis, but to give some entry point, baseline for a person. It used to be like that, now it's like that. If in a month you can see that the function is recovering, this will be actually a stimulus, a push to say, to stop saying I have this eternal concussion, it's forever. I will let Sergey. It's so important when military if they see on the screen that something's getting better, if there's a graph or a scheme, visualizing is important. You know, you have to show it to them. You earn their trust. There's certain empathy that you can get, and this compliance goes up, you know. So when you show it, we tested it with other guys. Again, there was one man with higher degree, and after concussion he reads 70 words per minute, you know, like in elementary school. That may happen as well. And if he doesn't do that, if he won't restore, if he doesn't restore, if he doesn't see his dynamics, dynamics motivates per se. You just have to show it's possible. If one shall not restore, you understand what's gonna be. So when we measured this, we demonstrated that we can differentiate with an algorithm. Was there concussion or not? But it's not about it. It's about cognitive reserve. Is there an opportunity or capacity to detour the damaged part? Something that is retrained in the brain to restore after the trauma, you know? And the key message that you want to give to people that your cognitive reserve is these are a lot of activities that you do, okay? Like education level, hobbies, sport, do you go to theater, do you play games or whatever? So if a person can split one's life into so many parts of this, like foundation, if it contains many components, the chance is higher for one to tackle it. It will be higher resilience then, I think. Something that actually Ksenia mentioned. That is something we do it for. So thank you. I absolutely support Serhi, and I just will announce instantly. Tomorrow we have one of the master classes, Cognitive Function Management, with CogSmart program, and it's pretty simple. You can, experts can learn very fast how to use that. So again, because with our MTBI, nothing is treated with medications, you know. I speak of cognitive functions now. So basically, there are no such great medications that would improve our memory, concentration, or attention. It would be great, and we would stay healthy and sane by 100 years without dementia, but it's myth. Okay. So these cognitive functions, we need to teach people to manage their cognitive functions, give the quality of life where a person will not notice or one will increase the neuroplasticity, but it's about going to theater. You have to go in for sports, guys. You have to look at something beautiful. It's all about neuroplasticity. Thank you, Serhi. I was reading about this King David test, and I read a paper. So it's mostly for sportsmen, but they just compared with school children. So sportsmen, they get rid of this minor trauma symptoms twice faster than those who don't go in for sports. So this is like about cognitive reserve, okay? Thank you. Okay, we speak of cognitive function. I think we'll go directly. I need to connect with Oksana. Oksana, hello. Hello, everyone. Yeah, I'm so sorry. Yeah, it's so sorry you're not here offline, but thank you for being with us online. And our cognitive function that is damaged after the trauma, it actually, this is something about what you want to tell us, okay? It fits in your speech. So your profession somehow covers that, but still, your profession is unique. And your experience is unique, and that matters. So you're welcome to give your speech. I think everyone will be really interested to hear this. Thank you so much, Ksenia. Thank you for inviting me to the conference. Thank you for organizing this because the topic of MTBI is super relevant today. And I'm so happy that finally we start talking about it, level of conference, with cognitive functions, damage, and we spoke also a lot about hearing problems. I will speak more like a speech therapist, but this also one of the specialists handling the auditory damage is audiologists. I do hope that we will have this profession also in our healthcare sector. I will talk about one of the consequences of MTBI, cognitive communicative disorders, and what actually the expert is doing with this speech and language therapist, which is something new for us. Okay, first of all, before I start, I want to express gratitude to American therapist Carol Roth Abramson. For more than 17 years, she has been working with American veterans in U.S. military hospital. If you read the book MTBI, translated into Ukrainian, and the chapter Communicative Therapy, if you look who's the author, it's actually Miss Roth Abramson. And she works with us since 2022. Regular meetings we have. She was actually delivering good lectures to us in cognitive therapy. One of her specialties is cognitive communicative disorders after MTBI. And last year, she even visited us in Lviv and Ksenia. We had a chance to have a joint panel. Okay, so I'll start with this. What we spoke about, that we have different types, different levels of gravity for TBIs, and you mentioned the MACE scale, and one of important components taken into consideration to detect that intensity, Glasgow scale, loss of consciousness, post-traumatic amnesia, hospitalization duration, and some abnormal things, found at CT, MRI level, or not found. So the mild TBI is when there is a high level of consciousness. When loss of consciousness, if it was like short, less than 30 minutes, if post-traumatic amnesia, less than 24 hours, hospitalization up to 48 hours, very short, maybe even no hospitalization, no abnormal findings at CT, MRI. And what's typical for this TBI is that patient, well, one is conscious, and it was spoken already. There's such an overlap between MTBI and PTSD, and both of these can have consequences for communication. When we talk about these communicative problems, this is not organic. When a person stumbles upon some words or sounds, it's psychogenic mostly. When we speak about also moderate or grave, such types of TBI can even lead to the organic speech disorders, and it's a little bit different. Okay, I'll speak in the end about it. But even the mild one may have no physical markers, but cognitive and communicative and cognitive. Okay, so we'd like to. I'd like to say today that communication is important, but it's not something mystic, okay? And we have so many studies, and there's a study in communication, not just an art, but communication is cognitive function or an umbrella of cognitive functions. Communication is interaction, of course, which stipulates certain domains. One of these is really important, cognitive, like for us to talk now, and I have to understand, each of us understands that now we are at the conference. We understand where we are. We perceive some information, and we can perceive it, hear it. We do it fast. When information for us is too complicated, we need to listen to it for a couple of times or read it. So how fast we perceive it, okay? Working memory, attention, mechanism of memorizing, learning, documenting, decision making, operations, and all these domains are important for our communication, because it's not just about talking per se. It's not about speech. It's about cognition. But when we express an opinion, this opinion should be initiated at some point. It has to be like planned. We have to put it in order. We need to pick proper concepts that we want to bring. Okay, so for this, we need cognitive functions. And these cognitive functions can objectively be assessed, and these can be tracked or seen. So we can't see it, but we can objectively assess it using specific tools. Emotional component, it's really important. Part of communication, anxiety, depression, frustration, anger, stress, or self-confidence. When we speak purely about such communication as interaction, then it's about receiving certain information. Not necessarily it's verbal, it can be visual, paralinguistic, mimics, gestures, signals, processing information that we receive, verbal expression of it, like oral or written. So this is a discourse. It's how we evaluate situation where we communicate. It's the understanding of what we read, capacity to write something. It's the capacity to interact with other people, social interaction. And physical components of communication, if we hear, if we see, articulation, voice, dynamics, smoothness. Also sleep, if fatigue, pain, this can affect communication. And all this shapes certain contexts where we interact. And we sometimes don't see on a daily basis that something special. We don't see that, we don't just notice that this can be like, this defines the quality of our life, or it's something that may be damaged. I mean, the cognitive functions, if certain brain trauma we has. And MTBI can actually also affect internal structures of the brain, which liberate certain cortex structures, or even certain parts that are responsible for cognitive process. So this all can lead to damage of cognitive communicative functions. It won't be manifested so harsh with like when we have the grave trauma when a person doesn't speak. But at the same time, for the person it will be hard to take part in like a conference. If person wants to bring some information but feels that it's like hard, one is slow down.
And so the person needs to hear some statement repetitively, and these are such kind of the, let's say, mild injuries. But we talk about inclusions, but we don't speak about like the inclusion like hard trauma, like wheelchairs and so on. But here we also have the inclusion, and this is the art of socializing and understand that the mild TBI can lead into the situation when a person makes let's say, illogical decisions. And so we have to provide the adequate cognitive therapy, but not saying that this person is like simulating something or so. And when we talk about the cognitive functions impairment due to the MTBI, mostly we talk about the memory loss. Like I can't remember, or I don't remember such information. But so that's why we have to bring the most or put attention in the focus, since here we will get the ability to understand the information, to listen to the information, and we talk a lot about how to get back the veterans into the work and employment. So maybe it will be hard for them to read some specific literature, and so they need a therapy of reading to develop a strategy how to keep up their attention, how to work with the difficult cognitive information, to process this information, to concentrate on receiving this information, and also the person can learn the algorithm of actions, but then this person will have the let's say the difficulty to make decisions based on this information. I will not dwell on all these items, but what I want to emphasize that we should not ignore the MTBI only because it's enough to some like IV therapy, and that's enough. Since every micron of our brain has its own function, and this function for us can be, let's say, not visible, but this function is very important for the qualitative life of people. Even when such persons get to neurologists, The neurologists don't do what to do with such patients, since it's not like they don't know what to do, but they see that something has been changed. But what really has changed? And we can and also must work with such persons. But it's kind of complex therapy provided in a multidisciplinary team. The patient should be in focus of attention, but we should not wait till these functions would improve within the patient. We have to create a specific environment. For example, when we just talk to a person and we see that it's hard for the patient to express his or her thought, so if we can leave or give him or her more time to do it, but not saying that, okay, I'll wait till you get better and then I will work with you. And plus, the support of the relatives is also very important. And when we talk about the cognitive function or cognitive impairment, it's not like a basket made out of unknown, but every aspect has its own clinical solution. So we have to refer such patients to a speech and language therapist in order to form these cognitive functions and then to build a good strategy. So, and not only limiting ourselves by pharmaceuticals. Since it's not the only support that is needed for the patient, since due to such trauma, the brain can change its functioning. So we can involve audiologists. Maybe it's a dream, but the dream can come true. We also didn't have any speech and language therapists, and that's why we can await that but we will get the audiologist as a therapist in order to form the behavior of this patient. And optometrist is also needed. Psychologists and psychotherapists, psychiatrists are also needed, and it's very important, in particular in the mild TBI, in its consequences with PTSD, and sometimes in order to work with trauma, we also need to develop a strategy to overcome PTSD, since they are overlapping. So the principles of the objectives of cognitive communicative therapy can be as follows, like attention, any type of attention, and we have to work with this attention function in order to for the patient to get the let's say the learning material, and then the velocity or the speed of information processing, memory, executive function, social communication, since we see that the service members after trauma, they try to avoid communication, they avoid socializing, not to look somehow awkward. And that's why we have to work here as the language and speech therapists in order to develop a specific strategy together with the psychologists in order to overcome psychological problems. Or there will be even more problems that we have to work with, and also the education, personalized or customized education for MTBI patients. It's kind of personalized education when we explain to a person with such impairment how to overcome this impairment, how to attain the objective. For example, when they have problems with reading and the serviceman wants to study at the institute, so we can develop the strategies how to do it well, how to organize its time, structure the information in order to understand the material read, and how to reproduce this material. It can be systemic instructions, so direct training of cognitive strategies. There are different strategies for memory and attention formation, but the effectiveness of the therapy comes when we combine this work with some practice and also the life of the person. And as I already mentioned, that in mild CBI, we observe the slaughtering at these persons, also the consequences of MTBI, but usually the organic impairments of the speech occur under the medium and heavy TBI. But when the slaughtering comes or occurs with the MTBI person, so this is the consequence of the stress or functional impairment. I've seen the soldiers with the total voice loss. And unfortunately, sometimes people simulate it, but I want to stress upon the specifics. What is the difference with organic impairment? It's because of some specific brain structures damaging, like when the ganglia are damaged, it can follow in the tremor or stuttering or dysphonia. We can observe stuttering dysphonia in the MTBI persons when, for example, a person is talking about himself or some, let's say, peaceful, recalling some peaceful moments. But when they start to talk to other persons or talking about his or her, let's say, painful memories, they start slaughtering. And the manifestation is different under different conditions. So that's why it's a functional impairment. It's kind of failure of programming, but not the as we in case we talk about hardware and software. It's let's say the software impairment, not the hardware impairment. And when the person talks in some specific situation but can't do it in other situations, so it's a functional dysphonia or stuttering. And those who can deal with this is the therapist of speech and language. Sorry, we have to finish at 6, so okay, I will speed up. So first of all, communication in the domestics and MTBI follows into cognitive communicative impairment, organic neurogenic impairments or damages due to the MTBI should be differentiated from the functional impairment. And the servicemen with cognitive communicative impairment can be cared by the speech and language therapist. Dear Oksana, as always, you are mega productive and mega informative and mega professional. We even can't, let's say, dispute with all your statements. Okay, we will talk with Mikhailo. Christina, video will be after that. And now Mikhailo represents one of my preferred rehab teams. This is also the Center of Excellence that we already talked about. Here, this is the hospital number 4 from Dnipro City. It's a big team with really unique professionals. They do miracles. They're quite professionally working with people with physical traumas. And for me, it's very important. I mean, their ideas are very important. And when telling why and what can physical therapists can do with the MTBI patients and why this is one of the aspects that we cannot do without. So let me mention the problems themselves. The first issue that the MTBI is not being considered as a trauma, then that's limited in undefined list of the medicaments, and then the physical therapists are underestimated with the MTBI persons, like saying, what can physical therapists do? You have to improve your neuroplasticity and this and that, and you'll go to the physical therapist when you'll be better. So, but when you ask such a person about what is neuroplasticity, they will not tell you or explain you, and they think that in case a person is lying down in the bed, so it's this patient needs nothing to, and just lying in the bed is enough for recovering its cognitive functions in language and speech and so on. And notwithstanding, the physical rehab has its own interventions that are linked with the patient condition. I mean, the patient does the tasks by himself or herself. We stimulate such processes which doctors try to stimulate with line injections, so we can stimulate them just with physical exercise, and it's what we do. So we have to put the patient in the focus of this multidisciplinary team, and together we have to work to help the patient to overcome these impairments. And it's not the sense that we will load in the patient with the physical exercising, but no, it's a whole complex with a whole range of components of from ergotherapy and physical therapy and so on and so forth. All the interventions are controlled and based on the primary assessment of the patient. Psychotherapists, their own assessment examination, the surgeons, their own, and so on and so forth, including cognitive functions in hearing and vision, in orientation, in the space. And basing on this assessment, we develop the relevant interventions, and the patient can do them, and also we develop the specific dosaging of this load. So when we're talking that if it's enough, 5 minutes is enough per day, so okay, it will be 5 minutes. So, and in case it's able to do even more, okay, we will provide more interventions.
And this problem that relates to, let's say, underestimating of or degrading, devaluating specialists. I can speak of this global scale because to our center we have so many teams coming to train, to study, for us to share the experience, and they tell the same things. And the worst thing is that those teams who don't have a strong leader or they don't have this well-developed unit, they start believing themselves that they are not important, as they think that they're secondary. But honestly, when we talk about rehab interventions and medical interventions, we always have to take it not in vertical but in horizontal dimension, because all our interventions are just for the patient and each has to intervene and contribute the capacity that helps the patient, but of course not devaluating each other. Yeah, you talk about the nurse. Yes, the nurse that is injecting something. Yeah, many doctors, orthopedics, neurosurgeons, they advise patients to have rest, okay? And it's hard to overcome when they go after the consultation from a very renowned institute, let's not give a name of the institute, where they are recommended not to move, just to stay calm, even after mild traumas, even mild physical traumas. Again, it's about breaking the stone with water, like drop by drop. This is a trend, like water breaks the stone. Yeah. The, the, the demand for change is there. Yes, it's a trend, but not everything is so bad. Everything's changing. It's flowy. It's changing. Even in our hospital, you can notice the changes because when we only established the unit, neurologists, they almost ignored us, and we even had conflicts. So they didn't allow us to go to patients only when, yeah, there was like a special case. They did, but when they required a bed. Now, the full scale war actually stimulated this process. I know it sounds horrible, but still, people go to seminars and trainings, and now even from the rehab unit, they called us and say, okay, we have a patient, a man, amputation, whatever. For 72 hours, he's not moving. Like, please, we'd like you to put him in a vertical position, like do something. We have changes that actually inspires us to move forward in this sector. Yeah, breaking the stone with water. And dearest, we have the very last part, the last speech from Christina Rakoczy. We met her when she came to us to Forest Glade in summer 2022. I guess that was spring when the big war started. So she came to us. She has Ukrainian origin, and she will give her speech in Ukrainian. So she is a specialist, a unique specialist, just like we had the speech and language therapist. Okay, we already have these in Teams, but optometrists, Optometrists, we have them in optic shops, and they help people to get their glasses. That's it. But this is not how it works. So this is a clinical rehab specialty, which actually is essential part of the team. And they help without medications to handle the ophthalmological disorders if it's not related to purely ophthalmological diseases, okay, if there is. But if the function is damaged, then we have optometrists. All right, so I think you will actually, this speech will be great for you. And for the first time, you'll hear some things that Christina is talking about. Okay, can we have her video? Hi, thank you for this opportunity to speak to you. My name is Christina Rakoczy. I'm an optometrist in USA, and I'm specialized in examination rehab of ophthalmological disorders after TBI. Optometrists of First Level Polytrauma Center at James A. Haley Hospital, Tampa, USA. I'm the head of the optometric clinics and clinic of visual function assessment. Also, an advisor consultant of the Ministry of Veterans Center of US. In July 2022, I visited National Center Invincible in Lviv, Center of Psychological Health and Rehabilitation for Izglade in Kiev, and other hospitals in the country to explain to American experts what are the needs, what is the demand, multi-sensory polytraumatic rehab in Ukraine. So I prepare some lectures for delegations of doctors and administrators who already visited the hospital in Tampa, Florida, Veterans Hospital for 4 times. I am a U.S. citizen of Ukrainian origin. So I just want to tell you what are the ophthalmological impacts when there is MTBI, how it affects activities. First, we need to understand the impact on TBI on the binocular vision, understand the impact of ophthalmological disorders on polytraumatic rehab. Third, understanding why do we need multi-sensory interdisciplinary examination before we start the general rehab, and psychiatric therapy. 4, demonstrate how multi-sensor rehab creates like integral recovery with one example of TBI with interdisciplinary examinations. Okay, multiple deployments and missions lead to so many damages and blast traumas and concussions, and it leads to multisensory disorders, chronic pain, PTSD, and other traumatic events. So, what American statistics tells us about these blasts and PTSD? So 62% of post-deployment cohort had over 5 episodes of blast, TBI 13. 90% of combat veterans with over 5 episodes of mild TBI with LOC had PTSD and or neurological deficits like loss of conscious. Numerous concussions lead to chronic symptoms. So PTSD and TBI have so many symptoms, and some of them are common, you know. Some happen purely with PTSD or TBI. The symptoms of PTSD include like these flashbacks on trauma, avoiding unpleasant situations, like being cautious, some nightmares phenomenon of repeated of living the same thing repeatedly. So TBI, headache, like sensitivity to light, nausea, also vertigo and others. PTSD and TBI, anxiety, annoyance, cognitive deficit, deprivation of sleep, depression, fatigue, and anxiety. So Look, sensory symptoms, just like problems with eyesight or, for example, vertigo, it's only for TBI, but not with PTSD. But sensory disorder symptoms actually impact and aggravate the PTSD. Multisensory deficits led by from various missions, military missions, lead to so many complaints from patients. Okay, we have hearing problems, vision problems, vestibular balance problems. We can have these all simultaneously negatively affecting the concentration, reading, walking, so performing some functions, etc. So the consequences of rehab for TBI, quite often, these are not successful. That is why. So two systems. So we speak of the vestibular and vision. These are interconnected. Optometrist or ophthalmologist in Ukraine, ergotherapist, who knows how to handle the vision disorders, they cooperate. So we examine these comorbidities, multisensory comorbidities, before the polytrauma rehab and also psychological psychiatric examination to understand if there are any impact of sensory disorders, general complaints, and mental condition. To ensure that we give better services with patients with TBI and polytrauma due to blasts, we need to have a special team of experts to coordinate the rehab of patients. So in the journal, Clinical and Experimental Studies, we have a paper, The Impact of Visual Impairment of Health, Function, and Mortality. Authors tell us that 70% of all sensory information comes in through our eyes. It's not just how good we see, but shape, color, distance, movement, and what's important, the position of head and body. So we speak about the metabolism of the ophthalmological system. 50% of our brain has to deal with it, processing, interpreting, and acting according to sensory data from the eyes. So in blog Energy Efficiency in the Visual System, they mentioned that visual system is one of the most energy-consuming systems of the brain. To process 70% of all sensory information coming through our eyes, brain uses 44% of all its energy to interpret the data. Any damage to the brain can lead to movements of eyes of the process and vestibulopathy. So ophthalmologists mostly check these eyes externally, and rehabilitation of vestibulopathy and vision, they do it from a different perspective. We take it internally. We look internally what brain is doing with all the data collected by eyes. Eyes are just like cameras, so they shoot the images. Brain is like a computer, controls the eyes, combining the images from both eyes, interpreting the image, and giving a proper order to the body to respond, to react. Doctors evaluate how brain is collecting data, processing data, interpreting data, and the response of the body, relevant response. So it's about equalizing these two images from two retinas. Therefore, there's a certain tone of 12 muscles in eyes. For binocular vision, to ensure that there's a proper depth perceived, we need to have stable positioning of images, projected into retinas. So this is coordinated by brain, actually, this process. If the brain is concussed, any natural positioning of eyes, vertical or horizontal, will not be corrected. Interpretation of data will be incorrect, and we will have deteriorated image, and quite often we have slowed reactions of the body. So damage from the concussion to these nuclei in the middle brain, and also specific nerves or vestibular apparatus can actually lead to aggravation. Yes, so we can have the reflex deteriorated in eyes. And it means that we cannot stabilize the image on retina, when we move our heads. The symptoms like some tilting, slowed thinking, slowed cognition, when you can't simply understand the text when you read it. When you have this foggy brain, headache, slowed body reaction. Mostly, these are not related to the vision damages. So, how we regulate the positioning and balance of our body in space? Vestibular apparatus helps us. When we change the position of the head or body moves, vestibular sensors get agitated and we have impulses. Impulses go via these channels in brain and to nuclei of the eye-moving nerves. This vestibular reflex helps our eyes move when we move our heads. So it has to be opposite to the head movement. So vision and vestibular data processing is to stabilize the way we look at something due to certain reaction. Clear collection of data in this process is needed to have proper response of the body. Based on the analysis of data, brain controls the balance and positioning of the body, and that's how we can walk straight. Okay, so we can understand why do we need after TBI very fast and even in advance, before other rehab or psychological examination to check the multisensory systems. Okay. So research in vision dysfunction tells us that patients with TBI with blast concussions are 2 times as likely to have vision dysfunction in patients with TBI from blunt head trauma. For example, like blunt head trauma when we have the car accidents or falling or something like this. People with TBI may have sensory, motor, perceptive, cognitive, and or psychological problems, or even psychiatric problems. 75% of people who had TBIs also can have relevant problems with vision if there are eye traumas because of the blast. Dysfunctions of vision balance due to TBI can have a functional effect on life and activities of daily living of servicemen, and of course the level of their performance, combat performance. Dysfunctions of vision, vestibulopathy are the methods for multisensory disorders related to TBI, but neither vision, nor vestibular, nor auditory, nor cognitive disorders, we cannot actually treat it in isolated manner, so only in complex. So typical symptoms. Patient complains there's headache, okay, migraines felt in eyes, becoming frequent, 2-3 times per 2 months. Light sensitivity, foggy vision, so vertigo, problems with balance, 1-2 hours that may last. People have to lie down. It's quite a random thing. There are no triggers. Again, vision. People are very sensitive to light, sometimes foggy vision, and also glasses for reading. Some noise in ears like tinnitus or losing hearing. Complaints for concentration and memory with short-term memory, especially forgetting names, words, conversations. So problems with sleep. Quite often wakes up less than 5-6 hours per night of sleep, sometimes nightmares. Psychological complaints, okay, like rage, depression, anxiety, annoyance, Also PTSD, combat PTSD there is. 20% of US combatants who served Since 2000 to 2021, they have the diagnosis of TBI. Majority of these classified as mild with their gravity. So TBI quite often is followed by long-term and let's say heterogeneous comorbidities like cognitive disorders, sensory disorders, mental health disorders, chronic pains, and sleep disorders, and it negatively affects the quality of life, functioning in family, reintegration in society. Okay, so vestibular symptoms and vision symptoms, which are more intensely manifested after blast trauma, one of the most typical symptoms after the concussion. During the study, veterans with TBI with mild and moderate level tell that they have higher indicators of vestibular dysfunction or non-specific concussion. So the forecast. The forecast is much worse for the recovery if there is vertigo.
Etiology of such symptoms to the blast is explained by the direct impairment of perfect vestibular apparatus and central vestibular channels and central visual channels, and through the anatomical nearness of the neurosensors ways that situated in the central nervous system. It affects lots of other spheres of central neural system functioning as a memory, learning, and sleep. So, summarizing, we prevent you for over accentuating on the life of the patient. Since the veterans, in such cases, they feel really, let's say, unnecessary, and it can lead into alcoholism or drug abuse, and treating altogether of all the claims or symptoms of the PTSD, vestibular syndrome, can help to shorten the period of distress at the patient, at the same time optimizing the functions, the quality of health in the brain in the long-term perspective. Those pictures of the American war veterans are similar to Ukrainian war veterans, but they are active. They also they try to defend us in Ukraine, in America. We all have our duty to give them, and to help them. Thank you for your attention. So, 6:02 p.m. It's really a miracle with lots of speakers and high activity. We managed to finish in time, and I would like to finish with a paradox statement that the heavy trauma has easy or mild circumstances. The mild trauma has heavy circumstances, consequences, and so yes, it can be easily. The heavy trauma can be easily diagnosed and treated, and the patient can come with a small neurological deficit. But in case we neglect the mild TBA, it can lead into all the consequences that we have been discussing today. So, let me announce our first day close. So we have 15 minutes of break before we present you a surprise, and we'll be here. So please come back. So 15 minutes of break, and we invite you back for surprise.